Okay, good afternoon, everybody, and welcome to our monthly Regenerous webinar. This week, introducing Labrix, a salivary diagnostic specialty laboratory who recently merged with Doctor's Data and have completed the stable from my point of view, because it's really nice to have all the hormone aspect to complete our offering from the combination of Doctor's Data and Labrix. We are very pleased to welcome our speaker today, Dr. Laura Neville, who is a staff physician at Labrix and who graduated from the National University of Naturopathic Medicine and combines her work at Labrix with her own practice in Portland, focusing on endocrine health. So a very warm welcome to you, Dr. Neville.
Thank you very much.
It's great that you're here with us today, and I know it's super early with you, so we really do appreciate your time. And just to put it into context for everybody who's listening, when we first started working with Labrix, we had a meeting to discuss testing and opportunities for testing here in the UK. And there's kind of a different approach here, because as a laboratory provider at Regenerous, our target market really is nutritional therapists who are not allowed to prescribe hormones and don't get involved in all the bioidentical hormones, which have had a huge surge in America, but haven't yet, they're kind of in their infancy here in the UK. So we wanted to do lots of education focusing around hormone balance and how to achieve that in the natural way. So looking at all of the diet, lifestyle, supplement changes that can be implemented for our patients who have many, many, many different hormone imbalances, which we see clinically every day. I'm sure, well, certainly I do when I'm seeing my clients. So the goal of this webinar was to introduce you to some of Labrix tests, but really to do that in an educational way. So I've seen the slides, and I know that Dr. Neville has a huge amount of information to get through, so I'm not going to take up any more time, but I will pass you over to Dr. Neville for what I know is going to be a really informative and really fascinating lecture. So over to you. Thank you very much.
Okay, thank you so much for that wonderful introduction. And thank you everyone for being here today. I am really looking forward to this presentation. We will dive into hormone balance approaches outside of the realm of bioidentical hormone replacement. At Labrix, much of our focus is in that bioidentical hormone replacement world, but that is not to say that alternative approaches are not just as valid and applicable. We have providers from all around the world who either don't have access to bioidentical hormones or simply prefer to approach treatment in a more conservative manner. So today we will talk about possible alternative modes of treatment. So this will include nutritional, lifestyle, nutraceutical, and botanical therapies. In fact, I'm thrilled to speak about these treatments because for providers using hormone replacement therapy, sometimes we can become a bit short-sighted and we lose these foundational pieces that are actually very necessary for true root cause healing. We have such a great array of practitioners here on the webinar today, so depending upon your style of practice, some of this may be review for you and others may be learning about these things for the very first time. Either way, let's celebrate the information. So the first slide here is on symptoms. The correct approach to treatment necessitates us to place our patients in either the category of premenopausal or postmenopausal. Remember that menopause carries with it this perimenopausal transition state that can last for up to approximately 10 years. So therefore, there is some symptom overlap, especially in those perimenopausal years. Starting with menopausal years, we're typically managing vasomotor instability. So that is talking about night sweats and hot flashes. So in the US, we use the term hot flash. I believe in the UK, hot flush is what you're using. Those words are interchangeable depending on the journal article origin. And so mostly dealing with that, but also quite a bit of mood issues, vaginal dryness, weight gain, brain fog, among the other symptoms you see here. Now, in the premenopausal years, we're usually dealing with PMS, which carries with it a vast array of symptoms, and also potentially PCOS. So it's common, I believe, in this age range for women to feel that these symptoms are just normal signs of daily life, right? Most of us in the US grow up thinking that these symptoms are completely normal, just a part of being female. I really like to remind my patients that while these symptoms are common, common is not the same thing as normal and should not be accepted as such. So a little bit of bad news here. You see this laundry list of symptoms here that we have to manage for our patients. The good news is that we have so many tools available in order to address all of these symptoms. And usually by targeting the hormonal symptom and treatment aspects, these can unfold and resolve cohesively rather than needing to chase each symptom one at a time. Okay, and we will want to remember the etiologies of hormone imbalance. In and of themselves, these can hint to possible treatment options. So I won't spend too much time on this slide. We'll get more detailed as we continue, but an overview of the names and causes are here. So we're talking about toxicity, stress. Sometimes I think we want to skip over this aspect because stress is this catch-all phrase, right? And it's so rampant, but it comes up again and again and again within the realm of health. Stress is highly attributable to hormone imbalance, and wonderfully, we have actually a direct way to measure this, and that's with the diurnal cortisol levels and DHEA. So we term that the adrenal function profile. Oftentimes, patients are quite unaware of the impact that stress has had in their lives, and so this is a nice objective way to measure how much that's impacted their physiology. We're also talking about poor diet or nutritional deficiencies and maybe poor GI health. Other endocrine issues can overlap here. For example, commonly thyroid disorders are going to overlap with hormonal imbalance. We could likely add age to this list as sex hormone levels naturally decline with age. So here is a treatment overview. This is not an exhaustive list, and notice that at least the first four subjects on this slide are the foundations of health that are universal to all beings. So if any of these aspects are not addressed and are out of balance, you know, we can really throw all of the supplements and botanicals and maybe medications we want at hormonal imbalance, but we will be battling uphill and true healing will not be reached. I like to think of nutraceutical treatments and botanical therapies as the cherries on top, right? I don't serve cherries alone. I try to create this foundational aspect first, adding those in as well. So starting with menopause, defined as the last spontaneous menstrual period 12 months prior. Average age of onset is 51 years, and perimenopause typically occurs between 3 and 7 years prior to this. With the prolongation of life expectancy, the menopausal and postmenopausal periods are becoming much more significant in a woman's life. So today, the average woman can expect to live at least 1/3 of her life in that postmenopausal stage, unlike many generations past. So it's imperative that we have an arsenal of ways to support women here. So there are hormone receptors all throughout the body, not just in breast and uterine tissues. It's not surprising why a drop in hormones during menopausal years creates such systemic symptoms. I suggest you may go back and actually spend a few times reading this slide to take in just how many tissues are affected. We're talking about not just the reproductive and urinary tracts, but also the estrogen-sensitive tissues, skin, bone, vascular lining, teeth and gums, the eyes, the brain, and the central nervous system. Sex steroids also affect sleep, libido, cognitive function, motor coordination, and pain sensitivity. In fact, we often are seeing depression and mood disorders appearing or at least exacerbating within this period of time. So it's no wonder that our patients are coming in with such a long list of symptoms. 75% of women experience hot flashes at least or at some point during this menopausal transition. And it's one of the most common complaints in clinical practice. The mechanism at this point is not fully understood. However, one theory here is explained. So diminished levels of estrogen and progesterone have a direct effect on the hypothalamus. That's the part of the brain controlling appetite, sleep cycles, sex hormones, and body temperature. So the drop in hormones causes the hypothalamus, which is that body's thermostat, to read too hot. And there's an attempt with different neurotransmitters here to dilate those blood vessels and cool down the body. So notice that we mentioned here a drop in estrogen and progesterone. All too commonly in practice, it is assumed that a drop in estrogen is what leads directly to hot flashes. Sometimes the estrogen levels are actually quite adequate, and it's the drop in progesterone which can be much more drastic, and that's a bit more to blame. The body has several ways to produce estrogen, which is less so the case for progesterone. So once ovulation is no longer occurring, progesterone production drops quite drastically. So some researchers suggest that lifestyle factors may play a bigger role in menopausal symptoms than previously thought. In 1970, anthropologist Marcia Flint studied menopausal experiences in women of non-Western cultures. She studied women in India and found that most complained of no symptoms during menopause other than menstrual changes. A decade later, we see Margaret Locke, who found that the symptom most likely reported by Japanese women during menopause was shoulder stiffness, and that hot flashes were actually very rare. In Hong Kong, researchers found that joint and muscle problems were the most common symptoms. In all of these studies, women were reporting symptoms as mild. So perhaps this can be explained by cultural differences in discussing health-related symptoms, but it also may allude to the hormonal impact of how we eat, how we sleep, how we manage stress, how we move our bodies, and how we live our lives. So the next 4 slides here are all on the subject of diet. So spoiler alert, placing high importance on this foundational aspect. Potentially, we could build upon therapies from here. So in Asian countries where soy is a dietary staple, women tend to get fewer hot flashes than women in the United States. But with studies looking closely at soy's effects on menopausal symptoms, the results have been quite mixed. In studies supporting soy to improve hot flashes, it does seem that food sources are superior to supplement forms. So this would include tempeh, miso, things like tofu, maybe edamame. This part is interesting, that the research is looking at a treatment interval of isoflavones requiring at least 48 weeks to achieve 80% of their maximum effects. So I think this is very important to discuss with patients so that they are not having unrealistic expectations about this. That timeline is quite a bit longer than I think most of our patients would hope for. And also, the subject of dietary soy is quite controversial. Some studies show no benefit to vasomotor instability. We also have this matter of phytoestrogens. Some studies are showing improvement in hormone balance, reducing risk factors, and other studies are actually showing a negative impact. So we're unlikely to resolve this controversy today, but know that the research continues and the soy story is ongoing. So here is quite a large study, just under 18,000 menopausal women who were not on hormone therapy. 40% were assigned to a low-fat dietary plan with increased fruits, vegetables, and whole grains. The other group ate their customary diets. So we see in the diet group, 14% were more likely to eliminate postmenopausal symptoms in the first year than those not on the diet, and that was a controlled study. The dieting women were 3 times more likely to lose weight than women who continued usual foods. But this part is most interesting. I think even the women in the diet group who gained weight were more likely to eliminate those same symptoms. So here, the American Journal of Clinical Nutrition followed 6,000 women for 9 years. They found that those eating a Mediterranean diet rich in vegetables, noodles, and red wine were about 20% less likely to report hot flashes and night sweats. And those with diets that were higher in fat and sugar were 20% more likely to develop hot flashes and night sweats. So you can see that there is some variation between diets in the studies that were discussed, but all show an improvement in symptoms. So taking this, I think we can say that dietary advice should be individualized, but there are common themes, and that includes a diet rich in whole and natural, unprocessed foods. So an emphasis in vegetables, whole grains, beans, seeds, nuts, fruits, lean, low-fat proteins, and healthy fats. Specifically, we have studies on flaxseed as a beneficial impact to menopause-related symptoms. Also, fiber and the brassica vegetables. These are shown to promote the metabolism of estrogens into their less carcinogenic breakdown products. There are some studies to support reduction in hot flashes with weight loss, but this seems to be what I call the Goldilocks story, as so many health aspects are. Being too thin may actually worsen symptoms of hot flashes, and body fat is actually an important production site of estrogen during the menopausal years. So once ovulation is no longer occurring, the body becomes a bit more dependent on the adrenals and the body's fat to create estrogen through aromatization. So exercise can help to deter hot flashes. Women who work out report that they're generally having fewer episodes than sedentary women. One theory is that exercise raises endorphin levels. Not coincidentally, the evidence shows that endorphin levels are involved in the regulation of body temperature. So the higher the level of endorphins, the more reliable the body's internal thermostat may be. And it's probably a good idea to have your patients avoid exercise within 3 hours of going to bed so as not to exacerbate night sweats. So there is probably not one aspect of health that exercise does not touch on. In my practice, I'm starting to use the word body movement rather than exercise because I think the word exercise is sometimes a trigger for patients. They want to move away from that or avoid it at all costs, while movement feels a bit more neutral, something that we can more easily gravitate towards. Movement also opens up the possibility of all forms and the ability to use this throughout the day rather than one given episode each day. So we see relief from hot flashes, improved circulation, improved ability to deal with stress. And what I personally feel like is the most important one here is increased self-esteem, mood, and frame of mind. This is all important to everyone, right? But a healthy self-esteem is so pertinent in the perimenopausal and postmenopausal years. Women often report feeling invisible in these years, and there are many who report that feeling invisible is actually worse than being portrayed in a negative light. So I really think this aspect of the menopausal transition is huge. So anxiety is strongly correlated with hot flashes. When I first read this, I assumed that hot flashes created anxiety, and this was the correlation. That seemed obvious to me. However, this study found that anxiety actually preceded the hot flashes. The study also revealed that women who had the highest stress levels were 5 times more likely to report hot flashes when compared to women with normal stress levels. So here are some stress management tools you may consider utilizing with your patients. Women are often the I-do-it-all types, right? Supporting maybe elderly parents, supporting children, grandchildren, working, being everything to everyone around them. But you cannot pour from an empty cup, right? You cannot help others if you are not taken care of. These recommendations should be individualized, so maybe ask your patients to choose 1 or 2 methods from the list. They don't need to do everything here, but whatever resonates with them. Some patients, especially of mine, tend to roll their eyes at meditation, right? But we have research to show a vast array of objective health marker improvements with meditation, blood pressure measurements, for example. So we can remind our patients that mindfulness or meditation is not necessarily a new age spiritual treatment, but actually a direct medical treatment and should be treated as such, just like a prescription medication. There are some wonderful apps listed here to guide newbies to meditation. So mindfulness training in hot flashes. This was a fairly small study, 110 people, but significant nonetheless. The frequency of hot flashes decreased by an average of 39%, and the severity of hot flashes decreased 40% over the course of 11 weeks. Additionally, a 28% improvement was seen in overall quality of life, with most women saying that they were better able to cope with their hot flashes after the stress reduction program. So these are some quotations from women who have gone through mindfulness training. These quotations I feel very strongly about. They give me chills because I think these are just so beautiful. I'll read the last two here for time's sake, but one woman says, "I am more aware than ever of my own ability and responsibility to change the course of my life and to choose happiness, joy, and peace rather than waiting for someone else or fate to deliver it." Right? That's so wonderful. I get chills when I read that because this is not just about hot flashes. This is improving these women's lives you know, overall, and that's so wonderful about this medicine. Another woman says, "If this is in fact midlife, I have another half ahead, and that's a lot of time to use the wisdom gained in the first half to make the second half richer and more joyful." So along the discussion of stress and anxiety, we can also talk about adrenal support. So prolonged stress brings about a dysregulation of the HPA axis, or the hypothalamic adrenal axis. Commonly, this is referred to as adrenal fatigue. And lifestyle changes to improve stress management and homeostasis will be helpful for hormone imbalances of all types. And again, as I mentioned in the past slide, we have an adrenal function test that includes diurnal cortisol points and DHEA. Those are objective markers that can help guide you with treatment protocols. A lot of times we're using B vitamins, especially B5 and B6, which help to manage the communication of that HPA axis. And then also vitamin C, adaptogenic botanicals like ashwagandha and holy basil. Those are just two of many, many adaptogenic botanicals. And then for elevations in cortisol levels, we consider phosphorylated serine. So you want to counsel patients on trigger avoidance as well when dealing with hot flashes. So diet pills, stress, hot tubs, saunas, hot showers, hot beds, hot rooms, hot weather, and smoking, everything hot, right? These can all trigger and exacerbate hot flashes. You can probably add alcohol as well to this list. Now, there is a connection to hormone imbalance and neurotransmitters. In the States, a pharmaceutical SSRI called Bridesdale is used to manage hot flashes in particular. Clinical trials have shown a reduced frequency of hot flashes by 57 to 59%. These studies were done with patients with at least 7 hot flashes each day. So this leaves us wondering if the SSRI might be effective in more mild cases. That remains to be seen. The dosage used in this case was much lower than is what is used to treat depression. Interestingly, those receiving the placebo reported a reduction in the frequency of hot flashes between 40 and 48%. So we see that there is likely a connection between neurotransmitters and the vasomotor symptoms. Achieving neurotransmitter balance is another effective tool to manage hormone imbalance symptoms. We do have panels that include salivary hormone testing as well as urinary neurotransmitter testing. And now we'll move on to nutraceuticals. So we're still talking about hot flashes here and those postmenopausal symptoms. So vitamin E at 400 to 800 IUs each day may reduce the occurrence and severity of hot flashes and night sweats. It's also providing additional benefits, strengthening the immune system and protecting the heart. You may consider B vitamins, vitamin C, magnesium, and potassium supplementation because hot flashes tend to deplete these nutrients from the body. Additionally, here, evening primrose oil at 500 milligrams 3 times a day. This is the source of gamma-linoleic acid and the precursor to the anti-inflammatory prostaglandin. This has been shown to reduce nighttime flushing. And nutraceuticals to modulate estrogen are listed here. Calcium D-glucarate. And this substance actually helps to reduce absorption of estrogen in the intestine and decreasing circulating levels. If you'd like to note here, the dosing for calcium D-glucarate would be 500 milligrams once a day to twice a day. We also have indole 3-carbinol or diindole methane. So this is a compound found in cruciferous vegetables. I3C forms a dimer diindole methane when it comes into contact with stomach acid. So these compounds tend to affect the estrogen metabolism, shifting the breakdown of the more proliferative estrone and estradiol towards the less carcinogenic of the metabolites. Diindole methane can be used at 300 milligrams each day, even twice a day. And indole 3-carbinol, we typically use 500 milligrams each day. So the aromatase enzyme is a sneaky little enzyme. It converts testosterone into estrogen. So the aromatase enzyme is especially active in adipose tissue. So this becomes a problematic process for both men and women, especially as they age. Using aromatase inhibitors, we can help to inhibit this conversion. There are pharmaceutical and natural aromatase inhibitors. The natural ones include the flavonoids, so chrysin, resveratrol, and luteolin. There are also studies on melatonin acting as an aromatase inhibitor. A study published in the Journal of Steroid Biochemistry and Molecular Biology found that chrysin was the most potent of the naturally occurring flavonoids. Now, Labrix offers melatonin testing, so you can access the levels here and work to improve melatonin levels, as it is shown to be an aromatase inhibitor. As I understand, in the UK, you may not have access to melatonin over the counter, but remember that dealing with light, blue light, and sunlight can also help to regulate melatonin levels. So on to botanicals. The uses based on historical and traditional bodies of knowledge have been around for generations, but the published research studies in this area of women's health have only been in the literature for about the last 40 years. However, the top 5 single evidence-based herbs for symptom relief in perimenopause and menopause are black cohosh, maca, kava, St. John's wort, especially when combined with black cohosh, and Siberian rhubarb. So I will discuss some of these herbs as we continue. So with black cohosh, there are over 125 published scientific papers and presentations on the efficacy and safety of standardized black cohosh. Typically, we're using doses of 40 to 80 milligrams each day. This can provide relief from hot flashes, as well as other menopausal symptoms, including headaches, heart palpitations, anxiety, and sleep disturbances. Note here that at least 4 to 12 weeks of treatment was required in these studies. Careful with liver disorders, you will probably want to avoid black cohosh in those cases. However, a nice summary here, black cohosh does not have an estrogenic action, does not contain phytoestrogens, is safe to use in breast cancer patients, The mechanism of action is a bit unclear at this point, but we are thinking, the most current thinking is that it's acting similarly to an SSRI. It has a pretty good safety profile. So maca is a cruciferous root growing exclusively in the central Peruvian Andes at 12 to 14,000 feet. So interesting to note here that there are over 175 different species of maca. Within that, there are many different phenotypes, each having a different color, DNA profile, and in many cases eliciting a very different physiologic effect. So if you are choosing maca for menopausal symptoms, be cautious of the species being used in that supplement brand. You may want to stick to the species listed here, at least in this study, as it was showing 3.5 grams of maca to show an improvement in psychological symptoms, anxiety, depression, sexual dysfunction, and that was when compared to placebo and used for 6 weeks. So valerian, here was a study of women ages 50 to 60, and they used 530 milligrams of valerian extract for, and that was twice a day versus placebo. So overall, 30% of the women taking valerian and 4% of placebo reported improvement in sleep quality. So poor sleep is probably one of the most common complaints of postmenopausal women. So I think this is a very important herb potentially for use. Siberian rhubarb, a randomized control trial used 250 milligrams here, and that contained 4 milligrams of dry extract. After 12 weeks, there was significantly decreased symptoms and no adverse effects were seen. Another observational study of about 350 people, again, used that same 4 milligram dried extract and saw a pronounced improvement in hot flashes, irritability, sleep issues, depression, and exhaustion. So here's a combination formula using burdock, wild yam, motherwort, dong quai, and licorice root. This study showed a 71% reduction in the total number of symptoms. So let's move on and discuss vaginal dryness. This is another top complaint in these years. We don't want to overlook hydration, right? Probably easy to start with supplements and going on down that road, but make sure you start with making sure the patient has adequate water intake. Lubricants can definitely be used. Also, Kegel exercises. This can help to increase circulation to that pelvic floor and maintain tissue tone. You'll want to have your patients avoid irritants to that area, which can create dryness or create sensitive tissue and exacerbate these issues. Taking oral probiotics has been shown to help balance that ecosystem of the vagina. Also, vitamin E at 400 to 800 IUs. This can actually be used and inserted into the vagina rather than taken orally. There is no need to break open the capsule. The pH of the vagina actually degrades that. You may also consider evening primrose oil, and this is oral dosing here. And as we saw before, that can help reduce nighttime flushing. It's also been shown to help with bloating, water retention, breast tenderness, and vaginal dryness. Vitamin E is another nutraceutical here. Careful teratogenic at high levels, right? But vitamin A is great at maintaining general tissue integrity and can be used as well. So acupuncture has been suggested as an alternative to HRT based on the fact that acupuncture increases central beta endorphin activity. It therefore may make that thermoregulation zone more stable and decrease hot flushes and sweating. In some cases, significant decrease has been reported not in the frequency, but actually in the severity of hot flashes. So one study here, the acupuncture arm showed no significant changes in hormone levels, although hot flash severity was reduced. This suggests that other factors are activated in causing hot flashes. We may be tapping into, these other aspects of hormone levels. We could postulate that we are maybe increasing receptor site sensitivity. This remains to be seen. Another study here showed vasomotor and physical symptoms were improved with acupuncture, although they found no changes or improvements in sexual functions and the reproductive hormones themselves. So here is a case study of ours. Pam is 55 years old, postmenopausal. The table here is showing you an actual report from a Labrix test, and this is our comprehensive hormone panel. So this is probably our most commonly run panel. You can see that Pam actually has elevated estradiol. While the progesterone is within range, the progesterone to estradiol ratio reveals to us that Pam is estrogen dominant, not only estrogen dominant, but progesterone insufficient when compared to that elevated estradiol. And because estrogen is a proliferative hormone, its job is to grow tissues. So progesterone is actually what balances that proliferative effect and helps to differentiate tissues. So to reduce health risk, we want to make sure Pam has a balanced PG to E2 ratio. We can do that by attempting to lower the estrogen level here and then raise that progesterone level as much as possible. We also see that there's an elevated testosterone and DHEA here. This signifies that potentially insulin resistance and dysglycemia is at play. Remember that aromatase enzyme, so if we have an elevated testosterone level, what we're likely seeing here is aromatization to create that elevated estradiol level. And then we take a peek at the cortisol levels. So while they are all within range, they are quite suboptimal. In our lab here, we call this HPA axis dysfunction phase 2. So we go all the way from phase 0 to phase 3. So we see Pam here in a phase 2. So this is a holistic treatment protocol we used with Pam. We had her avoiding triggers so as not to exacerbate the hot flashes she was experiencing. We also started her on a Mediterranean diet, so higher in fiber, plant-based, and including flax seeds. She had quite a high glycemic index diet prior to this, and so we think that was a lot of what was contributing to the elevated testosterone and estradiol levels we see from insulin resistance and aromatization. We had Pam meditate for 15 minutes 5 times per week with the Hello Mind app, which she really enjoyed. We had her doing resistance exercise, seemingly the most important type of exercise to improve insulin receptor sensitivity and decrease that insulin resistance we're seeing in the lab testing. So we had her do 30-minute sessions 3 times per week with a friend to try to get in that community support at the same time. We had her do diindolylmethane daily, and the dosing there we used was actually 300 milligrams twice per day. That was an attempt to help her body metabolize the elevated estradiol we saw into less carcinogenic metabolites. We added vitamin D at 2,000 IUs each day. This was based off her serum testing. And vitamin D has been shown, I have a study on this in a future slide here, to increase insulin receptor sensitivity. She was quite low in her vitamin D levels. We added vitamin E at 600 IUs daily, evening primrose oil, we added black cohosh, and we utilized some adrenal support with a B complex and ashwagandha. So let's take a look at follow-up testing. So let's see, the first there at the top left was her original report, and we're comparing that to a 6-month follow-up. So you can see that the estradiol level has now come down to within range, which is wonderful. That's reducing her risk. And then progesterone level has bumped up just slightly. This is often the case for a postmenopausal woman. You're not going to see a huge change in that progesterone level. after ovulation, progesterone is not being produced as robustly from that corpus luteum upon ovulation. However, Pam does have quite a reduction in the severity of her symptoms overall. So potentially we're working at that receptor site level of the progesterone. And most importantly, we've got her estradiol within range. You see here that the testosterone level, while still elevated, has come down quite a bit, right? So almost 10 points there. So that's really important. That's a very good direction. The DHEA level, we consider this follow-up testing still upper range, however, much reduced from the DHEA level we saw in the first case. Not only that, we're seeing a bit of improvement in her adrenal function and those cortisol levels. So that is all moving in the correct direction. And in fact, Pam is reporting hot flashes are less in frequency and severity. She has improved energy and clarity of mind. Her lipid profile has improved. Her blood pressure has gone down. And most importantly, Pam is now reporting a greater ability to manage the stressors in her life. So 6 months later, things are really, really improving in the correct direction. So back to our symptom chart here, we're going to move on to the premenopausal side. Because in these patients we're mostly dealing with PMS and PCOS, those are the areas I will focus on as we move forward. Again, many symptoms, right? But this can be managed in a cohesive manner by focusing on hormone treatments. So the slide here sums up PMS quite nicely, I think. The work of Dr. John Lee paved the way for many providers to begin treating patients without the use of synthetic hormones. So Dr. John Lee has several books out. I've listed one of them here at the bottom of this slide. Any of these would be a great resource for you if you're interested. Nutritionally, Dr. Lee found great clinical benefit when he used the following therapies that are all listed here. I won't go into great detail about these, but all very supportive for PMS in a nutritive fashion. And on to seed cycling. So there are several studies supporting the use of seeds in regulation to healthy hormone levels and reduction in symptoms, things like breast tenderness. But seed cycling, unfortunately, has no randomized clinical controlled trials. Yet, this has actually been used for centuries in traditional medicine with great clinical outcomes. The freshly ground seeds provide lignans, and this helps to bind excess estrogen in the first half of the cycle and is providing essential fatty acids. This is necessary to support ovulation and therefore really healthy progesterone levels in the second half of the cycle. And so don't forget about this connection again here between neurotransmitters and PMS. The relationship between hormones and neurotransmitters influences the severity of symptoms experienced by women with PMS. Suboptimal levels of neurotransmitters due to decreased synthesis or increased metabolism may influence mood, drive, sleep, emotions. Those are all the things we associate with PMS. So for estrogen, this increases the production and synaptic concentration of serotonin. It increases serotonin receptor levels and is a dopamine modulator, enhancing the activity of dopamine. Progesterone we see as a GABA agonist, and you can see here that adequate levels of hormones and neurotransmitters are really necessary for a successful relationship. Excuse me. So we saw this with Pam in that first case study, but elevated testosterone and DHEA in women signify really a red flag, right? So we consider that high or upper range DHEA and testosterone suggesting PCOS or metabolic syndrome, insulin resistance. You may consider serum testing if you're seeing these elevations in saliva, following up with vitamin D, fasting glucose, and insulin levels. So if you were to see normal levels in the serum, that would tell you you've caught this kind of metabolic dysregulation at an earlier phase. This is what makes, I think, saliva such a wonderful tool, is because we can intervene before more overt pathologies develop and are harder to resolve. So PCOS is the most common endocrine disorder of reproductive age. It affects 4 to 6% of women in the United States. We typically think of women with PCOS as being overweight or obese, but it's important to remember that women of all shapes and sizes can present with this disorder. Again, you'll commonly see elevated or at least upper range levels of DHEA and testosterone, potentially also lower levels of progesterone if they're having anovulatory cycles. So dietary recommendations would be based on managing insulin resistance. So potentially a lower simple carbohydrate load, increasing fiber, lower glycemic fruits, protein maybe at each meal, and healthy fats to slow the absorption of those carbohydrates. You may want to choose resistance exercise because that seems to be the most effective at glucose uptake into the cells and insulin receptor sensitization. You will see here a brilliant biphasic botanical formula. This can be used to stimulate ovulation and support progesterone levels and tonify those estrogen levels. So now, in case you don't have access to bulk herbs, there is a nice pre-made formula, or several out there. I will mention one in the next slide. Myo-inositol is actually used in particular in many studies to support PCOS, and there's great outcomes from that. Berberine has been studied to be as effective as pharmaceutical metformin to manage elevated blood glucose levels. Additionally, berberine is actually superior to metformin at improving lipid parameters, reducing waist to hip ratio, and increasing sex hormone binding globulin in these patients. Also consider optimization of vitamin D, which can increase that insulin receptor sensitivity. Okay, and we move on to botanicals here to treat PCOS. So these are the pre-made formulas that I spoke about in the last slide. Wise Woman Herbals has a formula called Phyto S, which is similar to that first formula listed in the last slide. Phyto Progest is similar to Formula 2 that you would use in the second half of the cycle. Here's another product. This is a product by Botanica called Ova Blend, which is specifically formulated to work with PCOS. And you'll see some nutraceuticals and herbals combined in that formula. It's a really great one. Additional botanicals here, fenugreek shows improvement in blood sugar and insulin levels, also improving lipid markers. Guar gum, lowering cholesterol, working with blood pressure and regulating appetite. And then we have apple pectin, beet powder, and oat fiber, right? All slowing the absorption of glucose into the bloodstream. We also have studies on milk thistle, gymnema. This lowers glucose and improves insulin sensitivity. It's actually been shown to regenerate beta cell destruction in the pancreas, which is really interesting. Also bitter melon. And as if that was not enough, we have all of these other protocols available to us as well for glucose regulation in particular. Cinnamon, fish oil, magnesium, alpha lipoic acid, all listed here and wonderful for blood sugar management. So vitamin D deficiency is common in women with PCOS. We see that the higher the vitamin D status, more correlation with improvement in insulin sensitivity. Just a few studies there on that information. So the hormone cascade. We want to remember that cholesterol is actually the backbone of the entire sex hormone cascade. The liver is also important because it produces much of the cholesterol within the body, and is also an origin of pregnenolone, right, which is also the precursor going from cholesterol to pregnenolone and then on down to the sex hormones. Remember that drugs that inhibit the liver's production of cholesterol may interrupt hormone synthesis, so things like statins. And then eating foods containing cholesterol will provide some additional support as well. So this is a wonderful slide. You may refer back to this many times. These are the steroid hormone cofactors. So cofactors, like neurotransmitters in producing serotonin, dopamine, right? We see a lot of the B vitamins intertwined all throughout this cascade, but also things like vitamin C, magnesium, and zinc. But this may be a great tool for you to refer back to in order to support these pathways. So here we have our second case study, and this is Joy. She's a 25-year-old female. We're seeing here in our comprehensive hormone report that she has actually low estradiol and low progesterone levels. This is signifying to me potentially she is having anovulatory cycles, maybe not every month, but at least the time that we captured in this test. That is something I'm thinking about when I see those lower levels. Testosterone is actually upper range, and DHEA is elevated. So that combination, elevated androgens combined with lower sex hormones of estradiol and progesterone, really makes me think about PCOS or metabolic syndrome. And then we see HPA axis dysfunction phase 1 here. Okay, so this is our holistic treatment protocol for Joy. I left off the most foundational part here, and that was her diet. Very much, Joy was eating what we refer to here in the US as a SAD diet. It's very sad. It's the standard American diet, very high in simple carbohydrates and processed foods. So we taught her a little bit about eating, which she was quite receptive to, changed very much what she was doing, adding in veggies and protein with every meal. That really did wonders for her. We also added in seed cycling, evening primrose oil, vitamin D. We're trying to work on that insulin receptor site sensitivity. We used a combination product here from that pathway chart that you saw, so including the cofactors to support hormone pathways. And then we had her make sure to turn off all electronics by 9 p.m., getting in bed by 9:30. She was really in the horrible habit of watching TV until about midnight and falling asleep in that manner. We added in exercise, so resistance training, 30 minutes twice per week, and also yoga 1 time per week. We're really working on her stress management skills. And let's see here. So follow-up testing. Follow-up testing is showing you some pretty great results. So this was eight months later after that program we placed her on. And now you'll see with the follow-up testing, this was our comprehensive plus profile. So let's just compare the values that we have with that estradiol level. We see that going from less than 1, so all the way up to 3.13. Progesterone level went from 102 all the way up to 325. That's a really great improvement there. That's probably one of the larger improvements you'll see in a progesterone level without using bioidentical hormones. And that's likely because she was not ovulating in that first test, and probably is now in the second test. So that's creating progesterone mostly from that corpus luteum after ovulation. That's where that progesterone level spike is coming from. We still see that her ratio of progesterone to estradiol is low, but symptoms have drastically improved. So again, we're probably working on that receptor site sensitivity. And so sometimes you'll see still what we consider progesterone insufficiency in these test results. But without the use of bioidentical hormones, it's quite difficult to get that into an optimal range. However, symptoms are vastly improved, so that's the good news. Testosterone level has come down, was upper range prior to this and is well within the range now at 25. DHEA level, while elevated in the past result, is now within the normal range. Cortisol level in the morning has come up a bit, but there is still a drop here in the afternoon. So Joy was so inspired by these changes, she actually started attending a naturopathic medical school. So not surprising to see these cortisol levels drop. We're still working on that for her. Okay, and we won't forget about the men. Hormone imbalance is just as important for them and often overlooked. So in females, we learned that insulin resistance leads to upper range or elevated testosterone and DHEA, but in males, insulin resistance leads to suboptimal or low levels of testosterone. So treatment protocols for men, we're trying to help them find new ways to alleviate stress. Excuse me, there we go. New ways to relieve stress, a nutritious diet, plenty of sleep, exercising regularly, group support, and plenty of water. I think the most important aspect here is that group support for men. At least here in the States, it's really not the social norm for men to have you know, groups of fellow community members where they're talking about their emotions, right? Men are taught to kind of stuff things down and just continue on even though there's great stressors in their life. So I think this is just a huge, huge aspect for them. So a study showing minimal hormone concentrations of testosterone in mice corresponded to high levels of anxiety. Another study finding stressful conditions reduced testosterone levels in normal subjects. So it's important to identify and relieve daily sources of stress in order to maximize the body's ability to produce testosterone in the first place and also retard the process of andropause. Rest and sleep duration is associated with androgen concentrations in men. So good night's sleep and good sleep hygiene are really important aspects here. So keeping the bedroom as dark as possible, removing electronics, and not watching TV or movies or working in the bedroom. Exercise has been shown to maintain testosterone levels. You can see here from the bullet points that we don't necessarily need to have high impact exercise. Things like Tai Chi and low movement exercise can be helpful as well. So we get to match the exercise program to the patient and their lifestyle and what they enjoy, which is great. Nutrition, eliminating and limiting sugar, lower glycemic index foods, healthy fats. Really, we're talking about a whole food diet here with high fiber and antioxidants. This is most effective in conjunction with exercise, of course. We always want that holistic, well-rounded approach because these treatments act in synergy. Okay, I know we're running short on time here, so I am going to be a little bit more efficient here in these slides. So zinc, you can read up on this and the studies listed below, but zinc supplementation is supportive of producing testosterone. Herbal protocols for men include Puncturevine, horny goatweed or epimedium, saw palmetto. This is actually shown to be a 5-alpha reductase inhibitor, have that activity. So we're talking about similar effect to finasteride, which is a pharmaceutical version. Stinging nettle root. This displaces testosterone from sex hormone binding sites, which is great because it renders more free or bioavailable testosterone to the person. So this is something of a holistic treatment protocol that you might consider. Zinc, we have diindolylmethane, rhodiola to support those adrenals, as well as the B complex, increasing fiber, and that weight-bearing exercise. We don't forget about adrenal health and neurotransmitter health overlap here, but you can see here we're addressing all aspects. Okay, So the adventure begins. Thank you again so much for joining me today. That was a lot of information. I hope that that provided you with some very foundational aspects. And I have full faith that your patients will be much better off with your support in using these guidelines. So again, thank you very much.
Well, Laura, thank you, Dr. Neville, so much for all of that information, which was just truly fabulous. And as always, when I go through these, I learn and pick up new things that I need to be reminded of that have slipped down my memory. But also thank you particularly for being a real pro, because there was a lot of background noise and to start with, and your wonderful team also asked your construction people to stop doing quite so much constructing. So apologies to all our listeners, and thank you for bearing with us, but really to you, Dr. Neville, you're a true pro for not letting that distract you. So thank you. We have, as always, had a few questions. My bad, I should have said at the beginning of this, if you have any questions, you can type them into the Q&A box at the bottom of your screen. Well, it's at the bottom of my screen. It might be somewhere different on your screen. It tends to jump around a bit on Zoom, or you can put them in the chat, but there have been a few coming through. So I'm going to go ahead and ask you some. We had one quite early on in your presentation about the form of flaxseed that would be best, as in soaked or milled. And I wondered if you had specific, I know later on you referenced specifically that it was milled. And I think, in my opinion, that's where most of the data is, that milled is best. But I just wondered what your opinion on that was.
Yeah, specifically for hormone modulation, it does look like the term milled, I am understanding is
ground.
That, yeah, ground, great. Yes, most of the research is in the ground or milled fashion of flaxseed, because that is actually able to open that seed and provide the lignins, which are really what's binding the estrogen and removing it from the body. So that actually doesn't seem to happen in a whole flaxseed. I'm typically asking my patients to have a little coffee grinder at home on their counter, and they can just easily do that. It does also seem to be necessary that that's freshly ground. So unfortunately, we can't grind vast amounts and freeze them. It doesn't look like that's working either. So,
okay, great. Somebody specifically said that you had a slide that sort of summarized black cohosh, and one of the reference points was that it was safe to use in cancer. And the practitioner that's fed this questionnaire said that it was her understanding that it was contraindicated with estrogen-related breast cancers, and wondered if you had the references that to support your understanding of the black cohosh being efficacious. So if that's something that you're able to provide me, then I can pass that on to the person asking, if that would be okay.
Yeah, absolutely. We'll find those studies and send them to you. And likewise, if that practitioner has studies on the contraindication, I'd be very curious to read that as well. It's just not my understanding from the research that we have done, but let's share on that.
Okay, brilliant. That sounds like it. And then we can all learn. So that's great. I like that. Somebody has also asked about brain fog and that as being a symptom of perimenopause, and if you have any specific info on that, or anything that you know works particularly well with brain fog in perimenopause that you found clinically.
Yeah, so I think, brain fog is quite it's kind of a catch-all phrase. Typically, we're thinking about progesterone insufficiency with brain fog, and that's a lot of times what we're talking about, but it becomes a little complicated because brain fog can be related to thyroid disorders. So there is some overlap there, as well as adrenal fatigue, I would say. But I would most commonly start thinking about progesterone insufficiency. How can I support progesterone levels? A lot of that's going to be done dietarily and perhaps with those seed cycling, that protocol that we talked about, as well as the herbal protocols. Especially in perimenopause, I'm not so much looking to create ovulation if ovulation is starting to wind down, but how can I work at the receptor site level of progesterone?
Great. And on the subject of perimenopause, when everything is a kind of crazy maelstrom of hormones, and if ordinarily in a premenopausal lady, we'd be doing the 1-day test on day 19, 20, 21, how do you give advice around when you should test someone in the perimenopause? I know it's a very difficult question to answer, but how do you normally gauge that?
Yeah, we actually have a nice handout that kind of breaks that down with every single, possibility of pattern in that. So it depends. Is there any, sense of when ovulation is occurring? Many times in perimenopause, most cycles aren't ovulatory, and so it's a little complicated to list. I'd be happy to share that document with you, that if you want to send that out to everyone.
Yeah, we'll do that.
Yeah, so we're trying our best to capture, and try to figure out when ovulation is occurring and work backwards from there. Sometimes we have absolutely no reference point. In those cases, I actually have them collect and then freeze the samples for a couple of days. If they do not start menstruating within 2 days of that, go ahead and send the sample in. If they do, we want to actually have them unfreeze those samples, rinse them out really well, and start over, because we know we've caught the hormone system at the very end of that cycle, and hormone levels, especially progesterone, are going to be very, very low, or the lowest of the entire cycle.
Right, we've missed the window.
Missed it, yes.
Yeah. Okay. Do you give age-related reference ranges for DHEA, or do you just have the broad range?
We have a broad range. So it is, there is a different range for males and females, but it's not age dependent. Cool.
That is nice. And as a clinician, what is your preferred form of magnesium for adrenals, and in clinic? What do you usually use?
I'm typically going for a citrate or a glycinate, which seems to be the most well absorbed into the body, rather than other forms which sometimes act as, to move the intestines a little bit.
Yep, don't want to give the wrong form for that.
Right.
Okay. And I think, here's another one. I have, sorry, it's just come in, let me read it. Okay, so just as general feedback to the audience, it's quite difficult to answer specific questions about patients. So the question has come through about imbalances in high estrogens, high E3, low E1 and E2, and low DHEA, and if you had any specific recommendations. Dr. Neville, I don't want to throw you under the bus, so if you feel happy to answer that, then do. But often, just as general feedback to all listeners, it's very difficult to answer for us as presenters, I think, to answer based on only knowing a tiny bit of and not knowing anything about the patient going on. But so do you have any guidance on that? So high E3, low E1 and E2 and low DHEA, does anything spring to mind?
Low DHEA, is that what?
Yeah.
Yeah, so with low DHEA, DHEA just declines naturally as we age. And so, depending, I think DHEA is tricky because it's a pro-hormone. You want to make sure testosterone is not elevated and you're pushing that higher. And if we're talking about a female here, and then that will also push into estradiol. But I'm assuming estradiol levels are lower because this patient may be postmenopausal. Elevated estriol levels, I think are interesting. Depending on how high it is, sometimes we're thinking about, transference of someone else that's using topical estriol. But if it's just very slightly above the range, I actually think that's a great thing, because estriol is the weaker form of estrogen, and so it's acting as a protective measure against the proliferation of E1 and E2.
Mm-hmm.
So generally lower E1 levels postmenopausally I'm not concerned about as well, because that's actually the most risky of the three, and it tends to elevate postmenopausally. And so if it's lower, I clinically don't worry about that. I may want to support estriol levels if the patient is quite symptomatic, and then DHEA as well, depending, though I'm cautious not to drive testosterone too high.
Great. Well, so sadly, here in the UK, we don't have access to DHEA, and nor do we have access to melatonin, not readily anyway. But yeah, so we are a little bit restricted here on some of the things. I know that you guys can get DHEA in like the supermarket, but we don't have that here.
Yeah, right.
There's been some feedback on your PMS cartoon as well, which we all love. So thank you for that.
That strikes a chord with so many people, so that's good.
Yeah, absolutely. And also, as you said, with men, I think for the community support, it's very similar here that, men, the same across the pond. We don't have those great networks that us girls seem to have with our friends and sharing of everything. So it's very much the same. But I think I don't see any more questions coming in. So I think we should wrap up and say thank you again so much to you, Dr. Neville, for your time and for this brilliant presentation, which, as I said, I've learned little things that I needed to be reminded of, and I know that all our listeners will have done too. And look forward to being able to host another one with you soon. For us as Regenerous, we have another webinar next month, which is towards the end of the month. I'll be shocked because I can't remember the specific date. It's towards the end of the month, and it is on neurotransmitters run by Doctors Data. So it's all coming from the same stable. And it's going to be more of an informal chat, a bit like our last presentation that we did. But we look forward to having you all joining us on that also. So for now, thank you very much and goodbye.